on the slides as they stand now is correct, but I just don't like how it's worded, and so I want to clarify for everybody because I got a lot of good questions, all right? So, forgetting the rest of the process that we talked about yesterday, just getting down to when the thyroid is making its hormone, okay? Everything on the slide in black font is accurate, but somewhat misleading. The thyroid does in fact make both T3 and T4, triiodothyronine and thyroxine, okay? It makes T3, which is the bioactive form of the hormone, in a significantly lower amount. So it makes, while it makes both of them, the thyroid gland produces both of them, it makes significantly more T4 than T3, okay? When the T3 then goes out on its thyroxine binding globulin, remember that? When that all of it travels on that, or on albumin, or on transthyretin out to the tissues, when it gets to the peripheral tissues, T4 is generally deiodinated into T3, which then becomes the bioactive form. Even though, as I said yesterday, T4 does have minimal biologic activity on its own. Does that make sense to everybody? What I'm saying? Makes both T3, T4, transported around on proteins of some sort, gets to the tissues. The most prevalent process of what happens, one iodine gets taken off, then it can interact with the thyroid hormone receptors on the target tissues, and then we have thyroid hormone activity. Does that make sense? A little bit? No? Does anything make sense right now? Is it just static? All right. Okay. Huh? Yeah.
What does T4 even do?
What does T4 even do? It's a prohormone, right? Generally, its main function is a prohormone.
But how does it grow if it's inactive?
A prohormone is an inactive, that's what a good point, that's what I wanted to bring up. A prohormone is an inactive form of, or a less biologically active form of a hormone. We're going to talk about a couple more today when we talk about the adrenal medulla, right? So it is essentially, think of it this way. It is something that will survive the first pass effect in either the liver or the tissues, and then have something taken off of it. And then at that point, when that thing is taken off of it, it becomes active. You're going to talk about multiple prohormones, yeah.
So the taking off to make it the hormone, yesterday you said it wasn't the iodine, or what, you did say it was the iodine that gets taken off. What gets taken off to make it the hormone?
From T4 to T3?
Yeah.
It is an iodine.
The iodine to make
the
it
iodine
T3.
is
Okay.
deiodinated by enzymes in the peripheral tissues.
Okay, I couldn't remember if you said it was or was not getting taken off.
I can't remember what I said.
I don't remember either.
No, but does that make sense?
It does.
And essentially, and it is. It's the same thing, just the chemical structure, right? It's going from 4 to 3, and the 3 and the 4 are representing the amount of iodine on the compound. Okay. Essentially, but it's called prohormone for some reason. You can call it prehormone if you like, but you'll be wrong. I don't know why they call it prohormone. Right? It is a precursor, but it's a prohormone. So there you go. Are we better or worse? Because I'm like, yes, sir. Yes, again, like we haven't talked about it yet, but there's such a thing like first pass effect in the liver. So when if it happens to be metabolized through the liver, sometimes the thing that is metabolized, as it's metabolized through the liver or the renal system, something is taken off, or it's chemically altered into another substance. So if it were sent out in a biologically active format, it wouldn't have the duration that it would need to actually have its effect on the target tissue. Right? A lot of exogenous medications, like medications that we give, or an isomer, or like an L isomer, or something else of a medicine that would then have something cleaved off when it's metabolized through the liver. That way, when it gets to where it's supposed to go, then it's active. Otherwise, it would just get digested or it would just get used up. Does that make sense? Yeah. Anybody else? No? Okay. Thank you. All right, here we go. Let's talk. Any other questions about yesterday? Any? Anybody? Okay. I'm just going to keep going. All right. The adrenal glands. All right. Adrenal, little hats that sit on top of the kidneys. All right. You may also see them called the suprarenal glands. They're the same thing. Okay. Just suprarenal, adrenal on top of the kidneys. Located where the kidneys are, superior to them. Okay? They have an outer shell, right? A capsule. That is not a physiologically active portion. It's just a capsule that keeps it together. Then what we're going to talk about portions-wise are the cortex and the medulla. The cortex is the outer portion, and the medulla is the inner portion. And then we're going to subdivide those portions based on what they produce. Okay? So we'll start with the cortex. These are the sections that we're going to discuss. Each one, I'll give you some hints while you're looking at them here. So the zona glomerulosa mostly makes mineralocorticoids, the main one of which is aldosterone. Aldosterone has an effect on the kidneys. So if you want to remember, zona glomerulosa has an effect on the glomerulus. Not one-to-one, it has an effect on the kidney. But that is an easy way to remember it. Because when you start to remember where things are made, glomerulosa, kidney, aldosterone. Does that make sense to everybody? I know we haven't talked about the renin-angiotensin-aldosterone system a lot yet, but it's just an easy way to put it together, right? Then, zona fasciculata makes most of our glucocorticoids. You guys learned about muscle fascicles yet? What a fascicle of muscle tissue is? A long, thin bundle, right? So the way this is named for is it's organized in these long, thin bundles. That's why it's called the zona fasciculata. And does anybody know what a reticular pattern is? Like a web-like or a lace-type pattern. And you can see here sort of a web-like, lacy appearance. So if you see anatomical pictures and you have to determine which section is which, that's sort of an easy way to give it away, just based on the nomenclature. Okay? All right. We talked about adrenal corticotropin releasing hormone, right? So corticotropin releasing hormone from the hypothalamus. Which part of the hypothalamus? Doesn't matter, remember? And what does the posterior pituitary produce? Nothing. Good job. There you go. All right. So where does the adrenocorticotropic hormone come from then? Huh?
Anterior?
The anterior pituitary, particularly which cells? Corticotropes. There you go. Just repetition. All right. And all of our adrenal cortex hormones are lipid soluble. All of them, or most of them, and in all cortisol, cortisone, aldosterone. Okay, so all lipid soluble meaning what? They can go directly into the cell. Okay. But what else does it mean? They need something to make them temporary water soluble so they can pass around in circulation. Okay? Very good. So let me explain everything on here. ACTH can stimulate and does stimulate all of the adrenal cortex as it's named, right? Adrenal corticotropin stimulating hormone, right? We got it. Glomerulosa, mineralocorticoids, also can be stimulated by this, the RAS system. Does anybody remember any of our discussion about the RAS and its relationship to blood pressure? Yeah, okay, right. It increases blood pressure. Kidneys, a fairly notoriously selfish organ, will clamp down on systemic pressure in order to maintain perfusion on itself. Right? So the second A in our AAS is aldosterone. So it can be dually stimulated in its aldosterone production. Okay? The other ones, ACTH, right? Again, so named because of what action it has. So mineralocorticoids on the outside, glucocorticoids in the middle, and androgens on the inside. Okay? Outer zone aldosterone, okay, zona glomerulosa. This is what I was talking about. The renin-angiotensin-aldosterone system exerts its primary effect on the kidneys, right? On the systemic circulation. So, the renal glomeruli in the zona glomerulosa. It's kind of an easy way to remember it. I don't know if that's why it's named that way, probably not, but it's just a kind of an easy memory trick, okay? So what does aldosterone do? Helps us get rid of potassium, okay? Mainly here, potassium in the urine. It increases it. And it also helps us get rid of hydrogen ions. So it has a very important role in acid-base balance, systemic acid-base balance. This point right here, which causes resorption of the sodium in the kidneys, and also one of the ways, instead of just helping with vasoconstriction, it helps increase intravascular volume by reabsorbing sodium. And then sort of the colloquialism is that salt follows water. So sodium reabsorption will bring water in it through various channels. Don't write this down right now, but there's aquaporin 1 channels and aquaporin 2 channels in the kidney and the renal tubules. Aquaporin channels either reabsorb just water through ADH or water and sodium with aldosterone. That's what we're going to talk about in the next block. Okay, but that's why it says sodium and water reabsorption. Okay, so there will be a difference. Okay, zona fasciculata, glucocorticoids, and I want you just mostly to remember this guy right here, cortisol. Corticosterone is a precursor of aldosterone, and cortisone, it gets converted to cortisol in the liver anyway, so, and they're secreted in minute amounts. 95% may be an underestimation of what is produced as far as cortisol in the adrenal cortex. Okay. What's up? Oh, you just did one of these like you had a question. No?
Which cortisol?
Everybody has too much cortisol and a stress hormone. One of the things that raises cortisol levels is stress, psychological anxiety, all right? And now you're all coming down from it. And so here we are. Your glucose is dropping. You're jumping into hypoglycemia. You have to listen to me do my little stupid song and dance up here. I feel bad for you guys. I'm sorry. All right? So, regulates glucose levels. What is one thing that glucocorticoids do that you probably already know? I'm sure you use them all the time, synthetic glucocorticoids. Anybody ever used hydrocortisone cream before? Huh? They're anti-inflammatory, right? You put hydrocortisone cream on your rashes to reduce the inflammation. You go to the urgent care and you get a cortisone shot, hydrocortisone shot, to reduce the inflammation in your lungs so that you can breathe better, so that you don't cough as much, right? So catabolic, these are not anabolic steroids, right? These are catabolic steroids, meaning they use stuff up. IGFs are the anabolic thing that we've talked about thus far. These are anabolic, or catabolic, so they eat stuff up, okay? They catabolize the tissue in general. When I was first training, they taught us when we gave exogenous glucocorticoids to be extraordinarily careful. Overcorrected probably, because the thought is if you give a patient like prednisone, which is a synthetic glucocorticoid, that if we were on it for too long, you would shut off their endogenous production of their cortisol production in their own body. In clinical practice, it's not nearly as dangerous as they make it out to be. So when you get to pharmacy, just remember that. But if you have patients who are at certain risks, like if you have somebody who has osteoporosis, somebody who is older, somebody who has an adrenal cortex problem, then you have to be a lot more careful with administering these steroids. Anything that you give exogenously, testosterone, cortisone, estrogen, growth hormone, has a risk of shutting off production inside based on those negative feedback loops, right? So the body's recognizing that it has a bunch of it, the production line gets shut down. And then sometimes if they're on it for too long, the production line doesn't turn back on. Okay, so anyway, that was a little bit of an aside. Protein catabolism, right? When we talk about the IGF growth factor, we talk about protein or skeletal muscle, bone, anabolism, growth of the bone in the muscle tissue. This is the reverse process, okay? So all of these things are meant to stabilize, raise glucose in the system, right? Stimulating gluconeogenesis. What does that word mean? Making new glucose, right? And glycogenolysis, right? Breaking down glycogen into its component parts, making glucose, right? Lipolysis to use free fatty acids for energy. Causing vasoconstriction. It has a sort of synergistic effect with norepinephrine. Remember norepinephrine is our thing that's secreted constantly in low levels to maintain vascular tone. So having a synergistic effect clamps down the vessels a little bit more, increasing systemic blood pressure. Okay. And then the big thing that everybody, like I said, that we already discussed that it's really famous for is a reduction in inflammation. Okay, so it reduces pro-inflammatory cytokines, which are cellular markers, cellular signals that increase inflammation. Cytokines, prostaglandins, things like that. Inside tissue inflammation. These things block those. Okay? Like I said, anybody here ever had poison ivy? Had to get prednisone for a while. Right? It breaks down the inflammation, reduces the swelling, the tissue, the itchiness, the redness, all of that stuff. Okay. When we have too much for too long, then, as I alluded to, especially with our osteoporotic patients or older patients who are at risk for osteoporosis, we have to be really careful because this does stimulate an increase in bone resorption. It weakens the bones over a long period of time. So somebody who has a disorder that increases their amount of cortisol production, which we're going to talk about here in just a little bit, runs the risk of developing premature osteoporosis or worsening the osteoporosis. Okay? Everybody know what I mean when I say osteoporosis, by the way?
What's why?
Huh?
Why is?
Because it increases bone resorption, so it turns those osteoclasts, it increases the osteoclastic activity. So we're turning it over and keeping it and resorbing it and not building it back fast enough. So it produces it. So osteoporosis starts on a scale from osteopenia, which is not enough bone mineralization, to true osteoporosis, which is weakened bone. And then on connective tissue, anybody ever heard of? We're going to talk about it, but anybody ever heard of Cushing's disease or Cushing's syndrome? Okay. Well, if you ever see patients with Cushing's disease or Cushing's syndrome, which is an overabundance of cortisol, you'll notice they have a sort of a heavy habitus, like it looks like obesity, but it's not a true obesity. It's a retention of water and solutes and stuff in the body. But what they have is striae. So striae are like stretch marks, right? And part of the reason why they develop these striae is because the fibroblasts, the activity of the cortisol in the skin causes the collagen in the skin to be weakened, and so it stretches easier, and so that's why they have those stretch marks all over their body, okay? And that's what striae are. It also does, over the course of time, suppress their immune response, okay? So what happens, you have this anti-inflammatory effect. It's sort of like a wear-out effect, kind of like the insulin resistance that we discussed. Right? Over the course of time, it actually has the reverse effect. And this is prolonged. This isn't a short course. This isn't a couple of months of prednisone. This isn't a couple of months. This is somebody who has Cushing's disease, who's had it for months, years, or longer, that eventually has a weakened immune system. Oh, let me go back. So, any questions about the middle section? Saculata, glucocorticoids. Yes, sir. Yeah, that's the only, when that, the rest of that, like I said, the corticosteroid and the cortisone are precursors to something else. Cortisone itself is a precursor to cortisol that's made through in the liver, and actually corticosterone has to do with mineralocorticoids, so it has nothing to do with this stuff. So yeah, focus on cortisol. Yeah. Okay, in the inner zone, again, more pro-hormones here, and we'll talk about that in the next slide, but weak androgens. So again, dehydroepiandrosterone and androstenedione do have activity. Ask Mark McGuire, if anybody knows who that is. But converted to testosterone or estrogen. So still pro-hormones. They do have some biologic activity, but their main function is to facilitate the conversion into the real androgens, the strong androgens, okay? And that's why I added this pro-hormone, because that is what these are, okay? And we are going to talk more about androgens when we get down into the gonadotropes later on. Any questions about those? We're going to do some clinical correlations. Some of that Cushing's that I was talking about. But first, Addison's disease. So Addison's disease is low levels of cortisol, hyposecretion, either autoimmune process or something that has affected the function of the adrenal cortex. Okay? So we're not making any of those things we just talked about. Low cortisol. So remember that cortisol increases our blood glucose, so we have chronic hypoglycemia. These patients are losing weight. They have low blood sugar. Okay? They have high potassium because they're not making that aldosterone to get rid of it through the urine. All right? And low blood pressure. Low androgen. So everything that we just talked about, that entire renal cortex, nothing is being made. So none of those effects are being produced physiologically. Now about this one, I want to talk about this real fast. Hyperkalemia, right? So we just said that aldosterone gets rid of potassium in the urine, helps us keep sodium and water to maintain blood pressure, right? So that does help lead to the hypotension. But I want to talk about the hyperkalemia and metabolic acidosis. What else did I say that aldosterone does to help to get rid of? Hydrogen ions, right? So if we're holding on to too much hydrogen ions, what are we going to end up with? Metabolic acidosis, an acidotic state. How then, does anybody know the physiology of how hyperkalemia can then contribute to further worsening of metabolic acidosis? Yeah, so what he said basically is, and I'll put it in even more generic terms than that, essentially what happens when you have too much hydrogen in the body is you will try to put the hydrogen from the plasma extracellularly into the cell intracellularly. In exchange, you will take a potassium from inside the cell and bring it out. So in high acidotic states, you can end up exacerbating it with in a hyperkalemia. It can even incite a hyperkalemia, and it becomes like a vicious cycle. Because what it's trying to do is take that acid in the serum and put it in the cells where it can't contribute to lowering the blood pH. Does that make sense? No? Some yes, some no. So if you have too much hydrogen ion circulating in the blood, where do we measure blood pH? In blood, right? If you have too much hydrogen ion in the blood, in order to try to maintain ionic balance, in order to try to maintain pH balance, like your body can only survive at a very narrow range of pH. It will try to sequester that excess hydrogen that's in the blood in the cell, right? Keep it out of circulation in the cell. In order to do that, it has to exchange a potassium ion out. So that potassium comes out of the cell into the bloodstream, increasing the potassium level, furthering the hyperkalemia, and actually worsening the cycle. Does that make sense, everybody?
What's the downfall of high levels of potassium? What, like hyperkalemia?
Hyperkalemia, ultimately cardiac issues. Remember back to the hyperpotassium, right? Incomplete repolarization of the myocardium, and eventually death.
Can you use aldosterone supplementation to fix this for the long term?
Aldosterone supplementation, no, what you need in the long term of this is, well, yeah, what you need is actually cortisol, what you need to supplement these patients with something that they don't have, depending on, So yeah, aldosterone, right? Aldosterone, some kind of potassium-losing diuretics, you can, and then what they really need is cortisol. But interestingly, they will also be very bronze. It's one of the giveaways clinically too. Remember that melanocytic stimulating hormone is stimulated by corticotropes, is made by corticotropes. So the excess ACTH, and why do we have excess ACTH? Because it's not being used, right? The hypothalamus is recognizing that we don't have enough cortisol, aldosterone. So negative feedback loop, turn it on. Let's turn it on. We need to make more, right? Similar thing to what we were talking about yesterday with thyroid stimulating hormone. If we're not making enough thyroid hormone, we need to make the thing that turns on the production line. So we have these huge amounts of ACTH, which is one way you diagnose this. And anyway, the excess ACTH actually stimulates melanocytes as well. So that's why these patients have a bronzing of the skin and a darkening of the gums. Okay? So you get this patient. This is not fake tan, this is actually just overproduction of melanin due to excess ACTH. And then also the gums. Darkening, blackening of the gums here. Okay? Hyperpigmentation. Cortisol. There's a difference between Cushing's disease and Cushing's syndrome, all right? Cushing's disease is if the pituitary is making too much. Cushing's syndrome is if the adrenal glands are failing, okay? Making too much, I mean. And then, what are glucocorticoids? Catabolic, right? High blood glucose, increased blood pressure, weight gain, striae, okay? So you see, if you've ever heard, or you will hear the term, a Cushingoid appearance, sort of like a moon face is what they call it, just a round face. They usually get a hump here in their lower cervical area. They get like a sort of like a fatty hump that develops right there. And then they have that striae, that centralized weight gain, and the thinning or weakening of the skin. So you see sort of just this round moon face, and then with treatment, returns to normal. So if you have somebody complaining of chronic weight gain, thyroid's one thing to look at, adrenal glands are another thing to investigate. These are the striae. Right? Comes from this not rapid weight gain and also the weakening of the skin. Okay? And if this doesn't make sense to you, after you get an organ transplant, what is your body's immediate response going to be to a foreign organ being placed in your body?
Attack it.
Overabundance of immune response, right? Inflammation. So we've got to tamp that down, right? So these patients usually have a lot of steroids to try to back down the immune system. Okay? Any questions? All right. The adrenal medulla. The chromatin cells are the functional unit. They make epinephrine and norepinephrine. All right, this is mostly the fight or flight response of norepinephrine and epinephrine. Okay. So, splanchnic nerves. Anybody know what splanchnic nerves are? Okay. They are visceral. They are abdominal innervation, autonomic nervous system innervation to the abdominal pelvic viscera. Okay. So they innervate the adrenal glands, and as we said, the catecholamines, norepinephrine and epinephrine, are hormones and neurotransmitters. And so that is the production, you can see here, the synapse of the splanchnic nerves releasing norepinephrine and epinephrine into the bloodstream. That's the more immediate effect, like fight or flight response. As soon as the stress hits, epinephrine goes up, right? And just as we talked about, increased heart rate, increased force of contraction, cardiac output, blood pressure. We need blood to our muscles to run away from the tiger, right? Open up the lungs so we can breathe while we're running. And what else? Divert blood away from abdominal viscera. Increase pupillary dilation. Increase glycogen breakdown. We need to feed the muscles. So that's what catecholamines do. That's the fight or flight response. Make sense? Not really? You guys feeling that right now? Running? Trying my best. Pheochromocytoma. Right? This is what happens. Pheochromocytoma is one of our favorite things to talk about here because I think maybe one of us has ever seen one of these in real life, but I guarantee you it will be a PANCE question. I guarantee you it'll be on the PAC rat when you're seniors. It'll be on your endocrinology exam. I don't know why. I think it's just because people like to say pheochromocytoma. It is a zebra. It is a unicorn. All right? So everybody know what I say when I mean zebra? When you hear hoofs, think horses, not zebras. This is a zebra. All right? This does not show up clinically, but you will be asked about it repeatedly. So what is it? It's a tumor within the chromaffin cells. What do you think that means it does? Makes too much catecholamines. So this patient is chronically excited. Okay, high blood pressure, edgy for no reason, right? All of these things. Fight or flight constantly. Okay? I know you don't have this picture, but I think it's better than the one that you do have. Essentially, you just have this big old chestnut in the adrenal glands. And the cure for it is surgery. We don't need to get into how you diagnose it. Urine test helps. But here's another one that you can see. So this is the kidney right here. And this is this big thing that doesn't belong here on top of it on the adrenal gland. Okay? You guys are making me tired. You need a break? You want to stand up? 5 minutes? We're almost done. But I just need something. Let me do something hilarious. Come on. Give me something. Do something. All right, we're going to talk about the endocrine pancreas right now. Endocrine pancreas. Remember, pancreas is endocrine and exocrine. We'll talk about the exocrine pancreas when we get to the digestive system. All right? Right here, sort of in the upper quadrant, generally left upper quadrant, right upper quadrant, sort of in the middle, right, in the epigastric area. Sits in the curve of the duodenum. That's where the head is. That's where it dumps its exocrine fluids into. Contiguous bile. So these ducts that you see here, these are the exocrine pancreatic ducts, all right? And these have to do with pancreatic juice and then the common bile duct. And dumps its digestive juices right here. So that's what we're going to talk about, the digestive system. Today, we're going to talk about endocrine cells, all right? I think probably most of you know what the pancreas makes as far as insulin and glucagon. All right. Alpha cells, glucagon, beta cells, insulin. I added this little bit right here in case you see this. A lot of times you will see it represented as the Greek symbols for alpha, the Greek letter alpha and the Greek letter beta. All right. They look like A's and B's, but I just want to make sure everybody can recognize what they are when they see them. All right. Delta cells make somatostatin. What else makes somatostatin?
The anterior pituitary.
Huh? Okay, here we go. What makes somatotropin?
Posterior
The anterior pituitary. What is the hormone that tells the anterior pituitary to make somatotropin?
Hypothalamus.
Growth hormone releasing hormone from the hypothalamus. So where do you think growth hormone inhibiting hormone also comes from? The hypothalamus. There we go. So we got there together. Okay? So it's made in two different places. And then F cells make pancreatic polypeptide, which does various things. Right? But we're really interested in alpha, beta, and delta right now. So this is a pancreatic islet. This is the endocrine pancreas. This is the functional unit of the pancreas, is the endocrine side of the house. All right. What does glucagon do? It raises our blood glucose level. Right? So, what would trigger the pancreas to make glucagon? Hypoglycemia. Right? Hypoglycemia, that's right. And then we have discussed how it makes that glucose, how it raises the glucose in various other methods. But glycogenolysis, gluconeogenesis, right? We're making glucose, raising the blood sugar. And negative feedback, right? As the blood sugar drops, glucagon production rises. Then as glucagon does its job and raises the blood sugar, that in turn inhibits the further release of glucagon and return to homeostasis. That's negative feedback. Does that make sense? Everybody? All right. Insulin. We all know what insulin does. It lowers blood glucose levels. We have to give it to some of our diabetic patients because their pancreas doesn't make it anymore. All right. So, how does it do it? Glucose uptake into the cells, right? If we utilize the glucose that's out there circulating, it goes away, right? So that's one way and facilitate cellular uptake. Glycolysis, what does that mean? Metabolism of glucose and making A&P2, actually physically using the glucose at the cellular level. And glycogenesis, the opposite of glycogenolysis, right? Making glycogen, taking glucose, putting it into its storage as glycogen in the liver primarily, right? So taking glucose out of circulation in various different ways. Utilizing it at the cellular level, storing it away in the liver. Okay? Is anybody still listening to me? You guys, today is a special day for you guys. I'm sorry that I had to follow this. I'm sorry this is Friday. I had to do like the mental gymnastics. Do I do this stuff on Tuesday, closer to our exam, or do I get it out of the way now so you guys have it and chew on it longer, and then we can do some of the easier finishing off material on Tuesday? So I went with this direction. I'm sorry, but here we are. All right, we're almost done. Just take a deep breath, and it'll be over soon. All right.
Where
Yes.
does the insulinotropic peptide come from? Does it come from pancreas as well? The GDIP?
Yeah, this actually it makes when we have food, when we eat, it signals the release of that in order to help functionalize and utilize the glucose and prevent the system from having a huge increase in glucose. So even a postprandial, like after you eat, your your blood glucose still maintains a reasonably low level. It doesn't shoot up into the 3 or 4 or 500. So it starts to metabolize any of that food right away. So it's a digestive reaction. It's a gastrointestinal reaction response.
Okay, so it's released by the stomach or the small intestine, or it's released is it being released by the pancreas, the GDIP?
Yes.
Okay.
No. Yeah. Now I got it. Sorry. Okay. So negative feedback, very much opposite. So if we have a raise in blood glucose from eating, from whatever, this triggers the release of insulin. As the blood glucose comes back down to normal, insulin release is shut down, and we return to homeostasis. Okay? Insulin, glucagon, much like we talked about at the very, very beginning, neither one is an on or off switch. We constantly have production of both of those to maintain our glucose in within a normal range, ma'am.
So during hypoglycemia, because I know we talk about the gluconeogenesis, glycolysis, different type of methods to bring up the blood glucose.
Right.
Like which method is gonna be activated?
All
they're
of them.
gonna happen the same.
The primary regulators of blood sugar are glucagon and insulin. All right. So if we're in a hypoglycemic state, primarily what's going to try to get it up is glucagon, right? But cortisol is going to have an effect too. So is IGF, right? So if we have a hypoglycemic state or hyperglycemic state, then primarily what directs the return back to a euglycemic state is insulin. So yes, all of these other things contribute, but these are the primary players. Glucagon and insulin, yes. Right? So depending on which way the blood sugar is. If the blood sugar is too high, insulin. Blood sugar is too low, glucagon. Right? Even though other background players have an effect, these are the primary mediators and moderators of our blood sugar. Does that answer your question? Okay. And again, this is just the roll up, okay, of everything that does. So again, if it helps you better to see it in a flow chart format like this, then just use this, okay? Somatostatin, right? From also the hypothalamus, as we discussed. Not necessarily a large contribution to growth hormone inhibition from the pancreas, but it does contribute for some. And then pancreatic polypeptide has to do more, although it's an endocrine hormone, it has more to do with digestive function, which is typically the crossover into the exocrine pancreas. So not a whole lot to worry about for pancreatic polypeptide from the F cells. Okay, so suffice it to say. And then this might get to your point a little bit here, ma'am, what we were just talking about. Because they do have background synergy. But this is just an interesting little gee whiz. We do need insulin and HGH for proper growth, right? HGH, human growth hormone, insulin to help maintain blood sugar levels. So, for some reason, they decided to take out the pancreas and the pituitary in a rat. And then it grew to this point, and then they performed the surgery, okay? And then you can see the growth sort of retardation, doesn't move. Then they administer just growth hormone by itself, and it increases just slightly, its growth, its weight. Then they give it just insulin, and it gets just a tiny bit bigger, but the line goes up higher. And then when they give it back growth hormone and insulin, it was able to have a more normal growth curve. So that might speak to your answer a little bit. It is primarily in stabilization once, when we're not talking about growth, right? In a child, in an adolescent, yeah, they're both extremely important. But once we stabilize, once our growth plates close, the primary drivers of our blood glucose or serum glucose are going to be the glucagon and the insulin.
So then what's the priority? What's the OML, I guess? Like which one is gonna go first, and if this one fails, and then what's the next one? Because we know that we can technically get glucose from
Okay, so put it this way. Think about this. Here's a way that you might figure. And you say, what's the OML? Which is, I guess, it's a good way to put it. But what do we replenish when we have a diabetic patient? Insulin, right? So the primary driver is going to be a replacement of that pancreatic hormone, not so much HGH, right? If we have an HGH failure, then we might supplement with that as well, or with IGF. But in general, if, when we talk about our real blood sugar, our main blood sugar comorbidity, right, which is diabetes 1 or 2, we replenish insulin, right, which maybe doesn't answer, but I don't know how better to answer. The OML, if that's the way you want, is for hyperglycemia. Hyperglycemia is insulin. For hypoglycemia, it's going to be glucagon, right? Because if you have a severe hypoglycemic patient, you give sugar, but you can also administer glucagon. Is that answering your question? Okay. Anybody else? Yeah. Glucagon is not sugar. Glucose. Glucose is sugar. Glucose sugar. Did you have one?
So this test, they took the pancreas and the anterior pituitary gland out of the rat.
All right. Yeah. All right. What's up? Okay, we are this close to being done, y'all. I know we're 2 minutes from break time, but all right. Quickly about diabetes. All right. Again, this is not endocrinology, but talk about mellitus. Literally, it did. Honey sweet. It tastes. They back in a long time ago. Tastes the urine. If it was sweet, they would determine it was diabetes mellitus. If it was insipid or bitter, it was diabetes insipidus. All right. So, you will hear this multiple times, the 3 Ps, polyuria. So patients are peeing all the time, they're eating all the time, they're thirsty all the time. Polyuria, polydipsia, polyphagia. Okay? We can't metabolize sugar, either because we don't have production, we have a pancreatic failure, or we have tissue insensitivity to the urine, so we have too much blood in the serum. That manifests with too much blood in the urine, which leads to the polyuria because glucose is a fairly large molecule. It's not supposed to be excreted in any significant amount, I should say, in the urine. So the water kind of follows it through an osmotic effect, and that contributes to our polyuria. And then you pee off too much water, and what happens? You get thirsty. All right? And then they're hungry too. Why are they hungry? Why are they hungry?
They want more.
Because the food that they're eating isn't being metabolized and used. They can't utilize the glucose that they're taking in, so they're hungry all the time. Okay? Diabetes is a great way to lose weight. Type 1. All right? So, type 1 diabetes, this is childhood diabetes is what you can think about, although it's being diagnosed in adulthood more now. You can screen for it now. These patients are usually our insulin-dependent diabetics. Okay, they have a true pancreatic failure, not necessarily a tissue insensitivity. So they are often discovered early. Usually in childhood, it's because of a failure to meet growth milestones. So they're not growing or gaining weight. And then they're exhibiting those other symptoms, and so then they get their insulin and everything stabilized. Generally, these are our compliant diabetics. Type 1 diabetics clinically are our compliant diabetics because if they don't take their insulin, they die eventually, right? Our type 2, no, so there you go, yeah. Treatment is strict blood glucose control and insulin replacement, all right? Both of these are, they're true, but individual islet cell transplantation is still in its infancy, but it's a possibility. So enough said about that. Type 2 diabetes, these used to be called our adult onset diabetics. All right. So it used to be called non-insulin dependent diabetics, but that is a misnomer because a lot of these patients are going to have to end up being on insulin. But usually the initial treatment for these patients are some sort of either oral glucose like metformin or some of our newer medications like Ozempic, which is what it's actually made for. Just has the side effect of weight loss. Okay. A lot of times we get these patients through routine. Sometimes these patients are found incidentally. we'll find them. We get labs for something else, and we find, glycosuria, too much sugar in the urine. We find hypoglycemia that's undiagnosed for some reason. Other times, these patients will come in exhibiting those overt symptoms of polyuria, polydipsia, polyphagia. I'm hungry all the time, I'm eating all the time, I'm always going to the bathroom. It's not your prostate, it's your diabetes, okay? So, and then again, yeah, I love this bullet. That's true. It can be controlled with diet and exercise and weight loss. But I hate to break it to you guys, and I don't want to break your hearts when you get out there and recommend therapeutic lifestyle changes to patients. They ain't going to do it. All right? An old man who comes to you who has been to the doctor once in the past 35 years, and he smokes and he drinks too much, and he's stubborn, and he doesn't want to be there. He's only there because his wife made him come, and his blood sugar is 650, right? Is not going to stop smoking, not going to start walking, not going to stop drinking. So just get ready for that when you're like, I sat down, I talked to that patient, I really broke through to him. Now you did. Yeah.
Could you ever
Yeah, man, you can literally control it with diet and exercise if you intervene early enough. And if your patient is, can you get rid of it? No. Can you control it where it is not, it is basically clinically insignificant? Yes, you can. Right? Type 1, no, you can't. But again, the longer it persists, the less that patient is, the less compliance that patient has, the more they continue to exacerbate their system by doing the things that got them there in the first place, the less likely that diet and exercise control is. So there is sort of a point of no return, if you want to call it that. Does that make sense? Yeah.
Is type 1 always genetic, or can it be like lifestyle choices from the mom?
Well, no, I mean, there is gestational diabetes that patients have when they're pregnant. They can potentially have a higher theoretical incidence of having a diabetic child, but it's not necessarily a genetic component one for one like that. Yeah. So, and then this is the last one you get. Okay. Hyperinsulinism. Most of the time, this is either iatrogenic, meaning we did it, or it is exogenous, meaning the patient did it to themselves. So this is what happens oftentimes when the patient doesn't follow their schedule, injects too much glucose, then they drop themselves into a severe hypoglycemia. And then we have to give them sugar and maybe glucagon. All right? So we'll do these, you know what, we're going to do these later. Get the hell out of this building.